resident in the Department of ENT and Head and Neck Surgery, Rajindra Hospital, Patiala, Punjab, India. Today, I'll be it's not moving. Tympanoplasty discussion. First of all, introduction. As we all know, the tympanic membrane plays a significant role in chronic inflammation. Is a very common disease, and tympanoplasty is a frequently performed operation in any ENT department. The primary objective of doing a tympanoplasty is to reconstruct the diseased tympanic membrane with perforation in CSOM, and the successful outcome is determined by an intact mobile tympanic membrane with good hearing. So several types of graft materials have been used to reconstruct the tympanic membrane. Commonly used autografts are temporalis fascia, cartilage, perichondrium, fascia lata, skin, and fatty tissue. And temporalis fascia is still the most commonly used graft material with high success rate. But due to the high failure rate of temporalis fascia in certain conditions like adhesive otitis media, subtotal perforation, atelectatic ear, retraction pocket, and advanced middle ear pathology, alternate graft materials which are more rigid and resistant to infection are being used, and cartilage graft has shown to be a promising graft material in such cases because cartilage is rigid and it tends to resist resorption, retraction, and reperforation even in the milieu of eustachian tube dysfunction, and it is more resistant to infection and negative middle ear pressure. Cartilage contributes minimally to an inflammatory membrane layers, providing firm support to prevent the retraction. It receives its nutrition by diffusion. It's easy to work with, and because it is pliable and it resists deformation from pressure changes. Now, there are various sites from where we can harvest the cartilage. As you can see in this diagram, there are various sites like scaphoid fossa, crux of phalanx, triangular eminence, but most commonly used cartilages are tragal and conchal cartilage. Conchal is preferred by some surgeons due to its concavity, but tragal seems to be used more often because it is harvested along the endoral root and it is less convex and is comparatively thinner than the conchal cartilage. Now, there are various methods of thinning the graft to improve the audiological outcome. You can use it with the scalpel. You can simply hold the piece of harvested cartilage between your thumb and index finger, and you can elevate the perichondrium on one side with the help of a scalpel, a cartilage clamp, a cartilage knife, or even a cartilage slicer is also being used. Notos has classified the 23 well-defined tympanoplasty methods into 6 main groups. Group A includes cartilage tympanoplasty with palisades, strips, and slices. Group B has cartilage tympanoplasty with foils, thin and thick plates. Group C includes tympanoplasty with cartilage perichondrium, composite island graft. In this, cartilage is harvested along with perichondrium on both the sides, and perichondrium is elevated on one side and it remains attached on the other side. Group D is tympanoplasty with special total pars tensa, cartilage perichondrium composite graft. Here only a single piece of cartilage is used to reconstruct the whole tympanic membrane. Group E is cartilage perichondrium composite island graft tympanoplasty for anterior, inferior, and subtotal perforations. Group F has special cartilage tympanoplasty methods, which includes chondroperichondrial clip tympanoplasty. Now, coming to our study, a prospective study on 40 cases of clinically diagnosed chronic otitis media was carried out in our department from December 2017 to November 2019. And the inclusion criteria included patients of COM with age group from 11 to 60 years. Patients who had inactive mucosal or safe chronic otitis media were included in the study. The patients also had intact ossicular chain and no history of mastoid surgery. And the workup included the detailed history, thorough clinical examination, examination under microscope, routine blood investigations, and radiology included the X-ray of mastoid bone, lost lateral view, and pre and post-op pivotone audiometry was also conducted to see the audiological improvement. Now coming to the method of harvesting the graft, in the post-oral approach, conchal cartilage graft was harvested. Incision was made along the entire conchal eminence. Perichondrium was exposed and both sides of perichondrium was elevated. The convex side faces the tympanic cavity. Perichondrium was removed first from the convex side, followed by the removal of cartilage perichondrium graft. For the endoral approach, tragal graft was used. Incision was given along the free edge of tragus and perichondrium covered cartilage was exposed on both the sides, medially and laterally. And it was cartilage perichondrium island graft was prepared by elevating the perichondrium on one side and leaving it attached on the other side. Graft placed medially with elevated perichondrium onto the posterior canal wall. This is a picture showing the harvesting of tragal cartilage and then the preparation of graft. Then after harvesting the graft and doing the surgery, middle ear cavity and EAC was packed with absorbable gel sponge. Post-op follow-up was done and audiological test was performed at 6 and 12 weeks post-op, and closure of membrane at the end of 3 months was accepted as morphological success. Now coming to the results of our study, the average mean of age of the patient in the study group was 34.8. 22 out of the 40 patients were females. Conchal cartilage was used in 34 cases and tragal was used in 6 cases. And no post-operative complication was noted in these patients. In our study, out of 40 patients, 34 showed the graft uptake and failure was seen in 6 patients. Now coming to the discussion, there are various factors like age, size and site of perforation, status of middle ear mucosa, surgical experience, which may influence the surgical outcome. In our study, 11 out of 40 patients were above 40 years of age, and high failure rate was observed in the patients above 40 as compared to the patients below 40 years. This could be due to the accompanying systemic disease in elderly patients. And graft uptake was higher in anterior perforations, that was 95% as compared to the posterior perforations. The reason for high graft uptake in anterior perforations with cartilage is because it is rigid and it resists resorption, and resistance to negative middle ear pressure prevents medialization and lateralization of graft. In our study, the graft uptake was 100% in small perforations, 87.5% in medial, 85% in large, and 80% in subtotal perforations. This is probably because of the larger bed that is provided for the graft, and there is a good opportunity for the graft to be taken in cases of small and medium-sized perforations. In our study, the success rate was 85% in terms of perforation closure. Graft failure was seen in 15% patients. The failure could be due to inappropriate size of graft taken or faulty surgical technique, or maybe because cortical mastectomy was not performed in any patient. The contribution of mastectomy to success rate of tympanoplasty is still arguable. There are studies advocating that in tympanoplasty in which cartilage is used, adding mastectomy does not affect the success rate of graft and gain in hearing. The type of failure seen in the present study is displacement of graft leading to reperforation. So this slide is showing the pre-op and the post-op picture. Pre-op perforation being closed with the cartilage perichondrium composite island graft, and it is also showing the audiological improvement. In our study, the mean pre-op PTA was 44.03 and the post-operative PTA at 6 weeks was 37.24 and at 12 weeks was 34.27. The mean hearing gain at 6-week post-op was 6.97 and at 12 weeks was 9.76 plus minus 2.12, which is clinically significant. Okay, so this slide is showing the various studies and the success rate with the cartilage graft and the audiological improvement. In our study, the graft uptake was 85%, and there was a significant audiological improvement with 9.77 plus minus 2.1 decibel. So based on the results of this study, it can be concluded that the post-operative closure rate of TM was high and audiological improvement was satisfactory and comparable to fascia with perichondrium cartilage island graft. So it can be preferred in reconstruction of tympanic membrane in revision cases because of their resistance to poor feeding, recurring infections, and retractions. So these are my references. And then I want to thank the organizers and all the participants for the patient